last lecture we spoke on Brugada syndrome.
You are in which year?
I'm discussing today on.
તમે કયા વર્ષમાં છો?
Yeah, I'm in third year.
એટલે પછી question એ પ્રમાણે આવે ને.
And now he is as good as consultant cardiologist.
Right. Okay.
So today's topic of discussion is long QT syndrome.
આમાં તો કંઈક જુદું જ બતાવ્યું છે.
So channelopathy. Mainly focus on long QT syndrome.
એટલે channelopathy is something beyond the cases.
Okay. Well, I will not discuss short QT syndrome and polymorphic ventricular tachycardia.
Not channelopathy of brain or myelin junction. What's that?
No.
Only cardiac.
Only cardiac channelopathy. So there are some glimpses of sodium channelopathy, potassium channelopathy, and calcium regulated channelopathy. These are the
branchable channelopathy.
apart from this, mainly the congenital and inherited.
But it is sodium, potassium, and calcium.
Calcium.
Voltage.
Voltage.
Here I have.
So only we'll focus on long QT syndrome. Other sodium channelopathy, Brugada, as well as early recurrent syndrome, cardiac conduction disease, congenital sick sinus, familial diabetes, and inherited infant death. Potassium related is long QT, Brugada, interceptable, short QT, early recurrent, catacolon, polymorphic, familial death, and other is. These are the description of the regarding channelopathy, but mainly the focus is on long QT.
नहीं एम नहीं कहता मतलब बोले तो मन तो किसी खबर नहीं तीनों की
routine day-to-day practice we mainly the inherited channelopathy.
तो कारण नाम मुकी दे तो channelopathy થઈ જાય?
No sir.
So what is gene as such?
Gene associated.
नहीं શું કરે છે?
Long QT syndrome.
તે એન્ડરસન કહ્યું.
Okay.
તો એન્ડરસન કેવી રીતે વિચારીશું?
So it will take another lecture on if you want to discuss all this. So all these related.
So Laljee, સાહેબે કીધું voltage gated channels.
Yes.
So voltage gated channels અને આ સોડિયમ પોટેશિયમ કેલ્શિયમ આ બધી સેમ થઈ કે અલગ થઈ?
Voltage gated channel resting potential and the action potential.
They are same of the different manifestations.
So these are voltage gated channels only, but they are permeable to different inorganic ions. It's like some are sodium, some are calcium, some are potassium. So તમારો આન્સર એ હોવો જોઈએ સાહેબે તમને જાણી લીધા આટલી વાત.
ના ભાઈ હું તો અજાણ્યો છું.
So these are the case of 44-year COVID patient having history of fever and diarrhea and.
Dear. What you are speaking? COVID patient.
Yes.
Right? We had a more or less nearly epidemic of sudden cardiac death. Right? And nobody was doing the postmortem. Young boy with the exercise, but dropped sudden death as such. Right? This was the phenomenon.
Yes.
And everybody thought that because of the thrombosis is very common. This is the heart attack.
This is benign after COVID.
But this was a painless sudden drop dead. It was channelopathy rather than coronary occlusion.
Might be under like channelopathy.
We have not done the molecular autopsy.
Yes. The majority of channelopathy baseline is normal, so we come to the thought about it.
So that is by the molecular autopsy.
More or less it overlap from the point of view.
બેઝલાઇન ECG પહેલા ક્યાં બધા પાસે હોવા?
When trigger factor is there, then.
Yeah, પણ આ જીમમાં કોઈ પેશન્ટ મરી ગયો 6 મહિના પહેલા કોવિડ હતું, કયો બેઝલાઇન ECG? What is baseline ECG? જો આ પેશન્ટનો ECG લો તમે જે નીચેની રિધમ સ્ટ્રીપ છે ને લીડ 2 વાળી, એમાં ઈચ બીટમાં QT પ્રોલોંગ થઈ રહી છે, દેખાય? પલ્સ રેટ બી ઘટી રહ્યો છે થોડો થોડો. Right, and as Petron said, suddenly went into tarsos ટોર્સાટ કારણ કે R1T થયું જો દેખાય R1T થયું ટોર્સાટ પહેલાનું જે વેવ છે રાઈટ. સો ધીસ ઇઝ વોટ ઇઝ હેપનિંગ. હવે આ તો આવડો મોટો ડોક્યુમેન્ટેશન થયું. આ ડોક્યુમેન્ટ કરવા વાળાને પોઝિટિવ નેગેટિવ બંને કોમેન્ટ આપી શકાય પણ એટલીસ્ટ ડોક્યુમેન્ટ થયું. ધીસ ઇઝ વોટ ઇઝ હેપનિંગ.
So, the patient on history of azithromycin and SU tablet and kind of maybe hypokalemia or
Macronidine.
Hydroxychloroquine.
Okay.
so maybe the
HCQSR name macronidine.
yes. So having diarrhea, we don't know underlying hypokalemia, drug induced, maybe triggering.
પછી એટલે કોને ખબર પડવાની છે? આ તો બધી હાઇન્ડ થિંકિંગ છે.
પ્રભુ એ તો વાયરલમાં બી ફીવર ડાયરિયા થઈ શકે. સીધું હાઇપોકેલેમિયા કરવાની જરૂર નથી.
So, in our routine day-to-day clinical practice, if 50 patients come, we don't measure all the patients to QT and QTC interval. So in basic routine life, if the RR interval, the QT is more than half of the this RR interval. So the rough idea is we can apply. So these lead to easily suggesting prolongation of QT, then R on 3 atomics, which alternative QT prolongation with alternate. These are the polymorphic VT because long QT plus this VT polymorphic VT torsade is equal. If patient doesn't have long QT, then we can not say it is a torsade VT. So how can we measure the QT interval? It is the beginning of Q to the end of the T wave. So more or less we can say it is a ventricular depolarization plus ventricular repolarization. So two events is there. So if we look into the Wiggers diagram, so the mechanical event happen is isovolumetric contraction plus ejection plus isovolumetric relaxation. So from starting from the Q to the end of T wave, the systolic event happen. So during that time, if we measure the
You are
exit
taking
potential,
me from first time to yes. Right on physiology. Right or Samson right on Western Taylor.
કાર્ડિયાક સાયકલ.
Okay.
so the exit potential of ventricular muscle cell, to compare with the QT, so these are the phase 0, phase 1, phase 2 and phase 3, ventricular depolarization and these are the repolarization. And phase 0, mainly the sodium channel is affected. The sodium channel is inward amplified sodium channel. Phase 1, 2 and 3, potassium channel, outward potassium influx, and is a plateau phase, calcium channel is inward. So these are the sensitive area, these are the repolarization area. So if any trigger at this point of time, it will lead to QT prolongation and so these are some example I want to discuss. If any mechanical trauma or any blunt injury in the chest, so what happens in this sensitive repolarization area? So when the suddenly the triggering factor happen at the repolarization time, then what happen? Patient may end up with the ventricular fibrillation or ventricular torsade is depressed. Other is these are the R1T phenomena. So when the ectopics on this P, then suddenly trigger into the ventricular fibrillation. These are the synchronized DC cardioversion when polymorphic VT or mainly we deliver the synchronized DC. So the QRS, the peak of R wave we deliver the synchronized. When we give this non-synchronized on mainly VF or polymorphic VT. So if the synchronized shock we deliver on T, then the electrical circuit will ultimately end up with the VF or cardiac arrest. So these are the example of cautery used during the operation. The electrical signal during the cautery which stimulate the T, then repolarization and circuit of calcium imbalance will happen. So mainly the three phenomena has been discussed in this. One is the early after depolarization. These are the sensitive area, calcium channel related, mainly responsible. So these are the triggering into the ectopics, and early after depolarization we trigger to the, these are the longevity and then VA. So another is the maintenance. One is trigger, these are the trigger. Another is the maintenance. It is the dispersion of refractoriness. Mainly dispersion of refractoriness in epicardial, myocardial, endocardial action potential. So if we find out the action potential, the subepicardial, subendocardial, and myocardial. Myocardial is more voltage than the gradient than the rest of the other. So the prolonged action potential will ultimately lead to QT prolongation, and then it will end up with the torsion before it. So these are the eyeball method. And if what happens if the T wave is not inverted or tangential, so we draw the line end of the T wave and do the tangential line, and then we measure from the start of the Q wave to the end of the T wave. So mainly we have to need two rhythm stream for measurement of QT interval. Apart from there we can use V5, V6. But mainly prefer.
So if the T wave doesn't touch its baseline, then we need to draw line tangentially or perpendicularly? Tangentially. That was new to me.
From the parallel to the tangent, it will be the idea about it. And mainly the QT depend on
the પાછળની સ્લાઇડ લે જો આમાં જે લેફ્ટ સાઈડ વાળી જે પેલી છે
yes
એમાં ટી ઇન્વર્ઝન પછી પાછું ઓફ સ્ટ્રોક બી આવે છે તો ઓફ સ્ટ્રોક તમે નથી કન્સિડર કર્યો શા માટે એ કયો વેવ છે
measure the end of the T wave.
So what is that off stroke? It is a part of T wave or something else?
No.
તો છે શું
No.
બાયફેઝિક T wave લાગે છે
Sir,
એ બાયફેઝિક T wave છે
how can I say this strange pattern?
What is this then? Is it part of T wave or it's not part of T wave?
It is not part of T
Then
wave.
what is it? ત્યાં એવું કયું એલિવેશન આવે તમે કઈ રીતે એક્સપ્લેન કરશો એ વસ્તુ It has to be some delayed after depolarize and repolarize, something like that. It has to be part of T wave only, URST only. Yes or no? I may be wrong. તે વાંચ્યું છે મેં વાંચ્યું નથી. But let me know that મારી દ્રષ્ટિએ T wave જ છે અને that should be included in QT. તમે જાતે ડ્રો કર્યું છે કોઈ બુકમાંથી લીધું છે?
This is the reference.
કઈ બુક છે?
This was on source from
સોર્સ અચ્છા સિનિયર આપ્યું છે આપણે નથી જોયું એવું છે સાબ આપ્યું લા જોજે યાર આ મને ડાઉટ છે મને
Shamrock. And what's the name of Shamrock?
yes.
પણ આ યુ નીડ ટુ કરેક્ટ મી તો મને લાગે છે કે પાર્ટ ઓફ ટી વેવ છે that it should be included in
Then it becomes more prolonged.
more problem yeah કારણ કે આની ઉપર બી તમારું જો આર વેવ ફોલ થાય અને આ પ્રોબ્લેમ હોય તો it can lead to હા તો તમે પાછા આ પાડો છો યાર એવું કેવું જોજે એકવાર આવતા બુધવારે કહેજે મને
I mean, so it is QT is mainly depend on the heart rate. If heart rate is patient is tachycardia, then the QT is shortening. If heart rate is low, bradycardia, then QT is lower. So our aim is to increase the heart rate. Because increase the heart rate will lead to QT. So these are the different formula: Breset's formula, Friday's formula, Framingham formula, and Walsh formula.
અરે આ 12મા ધોરણમાં તો ભણાયું જ નથી 11મા 12મામાં તો મેથેમેટિક્સ કાઢી નાખ્યું અને તમે એટલું મેથેમેટિક્સ શીખવાડો છો
હવે તો સાહેબ કોમ્પ્યુટરમાં આવી ગયા ને કેલ્ક્યુલેટર
એટલે માણસની જરૂર એ જ આવી ગયું
એ તો ગૂગલમાં બધું તૈયાર હશે ખાલી ફિગર જ મૂકવાની કેલ્ક્યુલેશન જ ક્યાં કરવાનું પહેલા ખાલી ફિગર જ મૂકવાની
સો યસલી
હા
હા પણ
જ્યારે
તમે
પણ કોઈ લેક્ચર આવે તો દેશ એ શબ્દ આપતો વિલિયમ્સ એવો શબ્દ નહોતો આપતો we have been grind with that thing how they have been arrived is more important than giving the formulas
બેટી બધી મહેનત નહીં કરવાની હવે કેલ્ક્યુલેટરના સ્કોરમાં આવતી તમારે ફિગર મૂકવાની એટલે સ્કોર આવી જાય
તમારે કેલ્ક્યુલેટર યુઝ કરવા માટે QT ના કેટલા ચોખંડા આવે છે એ તો ગણવા જ પડે છે એમાં તમારી ભૂલ હોય તો ખોટું આવે
ચાલો
Mainly routine practice use QT by under RR interval. So we have to measure the RR interval and then according to as well as QT, and then we can these are the equation of LBP. These are the formula that you cannot use routinely in this scenario. And these are the long QT. When we case to long QT, prolongation of action potential, as I discussed earlier, as well as increase the sympathetic activity. So long QT, the definition as per the standard definition as per the formula, characterized by delay reproduction of ventricular myocardium, resulting in the heart rate corrected QTC prolonged more than 480 milliseconds, associated with syncope, seizure, and sudden cardiac death, and underlying structural normal. So epidemiology is one in more than 500 person. Long QT may be responsible 20% autopsy negative sudden cardiac death in young patient, as well as sudden infant death in 10%. So mainly
Sudden infant
sudden
death.
infant death, and sudden young age.
infant death.
ये मेरा कौन डेट क्या करते हैं क्या जी
One terminology बताइए.
सी बेड साइड છોકરું સુરાઈ દીધું હોય અને પછી મરેલું દેખાય અને પોસ્ટમોર્ટમ કરે કઈ દેખાય નહીં.
In one of story I heard that in China or something, the ghost will come into night and sit on the face of a child and get suffocation and suddenly die.
Many theories come there.
So in presence of LBBB also the cutoff is up to 480 milliseconds. Okay, LBBB માં cutoff different છે.
LBB like
નહીં definition તમે જે કીધી કે 480 કરતા વધારે તો પેશન્ટ ને
Same.
કમ્પ્લીટ LBBB કે કમ્પ્લીટ RBBB હોય તો બી એ 480 કરતા વધારે હોય તો જ કે એમાં 500 કે 52
as per the
અને મેલ ફિમેલ માં બી ડિફરન્ટ નથી
male female difference.
તો કોણ કહેશે
So
તમે બિલકુલ જેન્ડર ડિસ્ક્રિમિનેશન નથી કરતા ને બહુ ડાયરેક્ટ
sir, in
મને
male,
ડેફિનેશન માં આવું જોઈએ ને પ્રભુ
one of the slide I mentioned, these are this was I forgot to discuss, but in normally 440 millisecond in male and 460 millisecond less than these are the criteria, and if the 470 more than 470 millisecond in male and 480 millisecond in female, then we can consider it
In normal sinus.
normal
Sinus.
sinus. So mainly there are two types, congenital and acquired. So in routine day-to-day practice, very hardly rare cases of congenital. Majority of time either
The history will give that.
yes, family history or
Right? 3 generation history is the compulsory.
but in our 2 years of residency we don't get any.
You
Don't
know,
have time.
3 generation history.
Don't have time.
See, જે તમે
Neither
પૂછ-
patient has got time, nor doctor has got time.
તમારી લિટરેચરમાં ઘણી બધી વાર એવું લખ્યું હશે કે ઇટ ઇઝ નોટ અનકોમન ઓર ઇટ ઇઝ રેર. આનો મતલબ શું કે આપણે જોતા નથી, જોવા નથી માંગતા. If you start looking, then so many things will be visible. કારણ કે આજે કોઈ 20 વર્ષનો QTC માં મરી જશે ને તો તમે મેક્રોલાઇટ ડિઝીઝ કે નહીં જોશો, તમે ફેમિલી હિસ્ટ્રી લેવા નથી જતા. અને મેક્રોલાઇટ તો ક્યાંક લીધી જ હશે કલાકારે, એટલે આપણે સાબિત કરી દીધું કે આવું QTC છે. So that's the case.
એટલે મેં કહ્યું કે all sudden cardiac death should have a
Molecular.
molecular autopsy. Routine autopsy will be totally normal. See, સ્કૂલનો છોકરો કસરત કરવા ગયો અને found sudden death. It's a nightmare to all. School staff as well as parents cannot accept the reality. People have done 3 times postmortem in a Bangalore on the insistence of parents as well as journalists. Journalists come in the picture, then lawyer comes in the picture. Nobody has thought of giving the molecular autopsy.
હવે તો સાહેબ પેનલ ઓટોપ્સી નથી કરતા, પોલિટિકલ પ્રેશર હોય તો મોલેક્યુલર લાગે ત્યાં વિચારે.
So congenital long QT syndrome caused by the inherited channelopathy created a mutation, one or more in either maybe the gain of mutation or loss of mutation associated with this disorder, So these are the molecular.
What you have told. One or more genes.
Yes.
If a healthy individual in family history, one gene is mutated, is a potential candidate to get the long QT. Now, if he says that, what are my chances of dying suddenly? Can you predict it? Can you prevent it? I am more concerned with third people.
Chances of if one gene is involved, it is chances of 35%, 35 to 40%.
Would you like to correct him? અંબાણીનો છોકરો છે. અંબાણી માણસ નથી.
Then go with the genetics. Molecular panel.
There CRISPR will come. You know the things? CRISPR is the genetic changing the spare parts. Only the one spare part is being taken out which is defective, and adenovirus will put the appropriate spare parts and it's cured.
Gene knife जो है gene knife.
It is not simple knife. This is a precise knife. So only two ends are cut with a precision, and then new spare part is being put with a CRISPR. The idea is coming in the sickle cell. Only at the sixth position, only one amino acid is defective, altered. If you change that amino acid, sickle cell disease goes away. It will come here.
Gene therapy.
Gene therapy. So molecular basis of long QT, different. These are the list of around 7.
Now you have come to Anderson antibody. Where the fault lies as such.
So a patient has isolated cardiac condition or associated with extra cardiac condition. Based on this, can guess what are the underlying gene.
Why this is important?
First thing is for diagnosis. Second thing,
It has become cheaper. Previously, all genomes were very, very expensive. Now it comes in a few thousand rupees only. Previously it was in a lakhs of dollars. In 2002 to 2024, only improvement is that it has become very cheap. So if you find this gene as such,
gene therapy, I heard that Bangalore and beyond this.
many, many.
So you know what are the charges right now?
18,000 rupees.
ના ના સર ઘણા ઓછા છે. તો તમે કયા સેટ ઓફ જીન ને કરો છો એ
એના
પ્રમાણે
પર
10 થી લઈને 25 સુધીમાં મોટા ભાગના જીન એનાલિસિસ થઈ ગયું. 10,000 થી લઈને 25,000.
Okay.
So mainly focus is to the major long QT which consists of 75%. Rest of the minor long QT is that is Anderson-Tawil and Timothy syndrome. QT long QT7 is Anderson-Tawil and long QT is Timothy syndrome. So these are the gene affected KCL, Q1, associated long QT1. Majority of patients having sudden cardiac arrest which belong to this group, long QT1. Another is KCN H2 gene associated long QT2 and SCN5. Yes, these are theoretical aspects.
નહીં ગોખવાનું છે. KCL and Q1 કેવી રીતે સ્ટ્રીપમાં દેખાય છે કેવી રીતે ડિફરન્શિએશન છે that is more important.
Molecular aspects.
બરાબર છે નહીં તો આ તો જે છે જ સ્ટોરી ચાલે છે એ કયું આપણે માની લીધું.
So how is the inheritance of all those genes? Are they recessive? Are they dominant?
These are the autosomal dominant.
All?
All, yes. And these are the autosomal recessive.
Which these એટલે તમે મેજર ને માઇનર ને કયો છો? અચ્છા આગળ આવવાનું હોય તો રહેવા દેજો બેટા ઇંગ્લિશ ના ઠીક છે.
JN1 and JN2, these are the autosomal recessive, and all these autosomal dominant. So, acquired causes. Acquired causes may be various drug, which drug. Here are the list of drug, anti-arrhythmic drug, mainly class anti-arrhythmic drug, class 1 and class C is progesterone. Class 1B and class 1C. For the treatment of we give class 1C, class 1B. Takinide it is increase the QT interval. These are the amidol, sotalol, quinine, procainamide, dopamine, and glutaret. These are the antimicrobial, anti-depression, antipsychotic, and others. Apart from the hypocalcemia, hypomagnesemia,
because of long QT interval, we drug time. અત્યારે એક્સટિંગ થઈ ગયું જે અમે બહુ લખતા હતા સીસાપ્રાઇડ પ્રોકાઇનેટિક પછી એટલે એ લોકોએ ફાર્માસ્યુટિકલ કંપની મોક્સીપ્રાઇડ ને બધા શોધવા માંડ્યા કે અમારા નથી થતું કોણ જોવા ગયું આપ જોવા ગયું છે મારે ત્યારે ખબર પડે
mainly used in cancer,
anti-motility.
IBS માં
chemotherapy induced.
ના IBS માં
IBS નો સીસાપ્રાઇડ પહેલા
બહુ યુઝ થતી હતી
સીધા
એ ડ્રગ મળી ગઈ
And
because of long QT interval. Therefore, very good. But because this thing came as such, because matter.
સીસાપ્રાઇડ ને પોતાને VTVFC.
મેક્રોલાઇડ માં જે રોક્સિપ્રોમાઇસિન કે એ આદિ છે ને એ પણ લખી રહી છે
એ દેખાતી નથી.
હવે ઇન્ટરેસ્ટિંગ કહો
હા
પાર્ટિસિપેટ બેઝ પોઝિશન રોક્સિપ્રોમાઇસિન એઝિથ્રોમાઇસિન બરાબર એઝિથ્રોમાઇસિન ચલાવી પ્રોક્સિપ્રોમાઇસિન કાઢી મૂકી બધાના ગોત્ર તો એક જ છે મેક્રોલાઇડ જ છે
Yes.
મોલેક્યુલર સ્ટ્રક્ચર રાઈટ સો હિયર કમ્સ ધ multinational companies picture how they brainwash you સિંગાપુર કોણ લઈ જાય છે કોણ નથી લઈ જતું
So, other non-characterization is these are the list of radiation, CNS, microproblems, and hypokalemia, hypomagnesemia, hypoglycemia. So, as per the QTC, increase the mortality and
That was new character. 1993 ની વાત છે ઓકે
So which endocrine disorder can lead to QTC prolongation? Hypo? Yeah, practically you are right. Hypoparathyroid, even hypothyroid, and pheochromocytoma, all three.
pure does by what mechanism all are having the different mechanism
Yeah.
category બરાબર એટલે ટોક્સોલ કોર્ટિસ કરશે
only catecholamic polymorphic.
જ્યારે હાઇપો ને હાઇપોપેરાથાઇરોઇડ તો એ ટોક્સોલ કોર્ટિસ નહીં કરે પછી કરશે
It will lead to hypocalcium and it will lead to hyperprolactin. Same goes with hypothyroid.
So, patient having kind of when it may be transient VTBF or studies before and patient regain the consciousness and recover. So, palpitation, pre-syncope, syncope, and as well as cardiac arrest. These are the presentation. Some other disorders associated with QT prolongation is associated with deafness and cerebral hearing loss, like Jarvell language syndrome. So, mainly these are the discussion points. These are the one slide about differential.
ન્યુરોનલ ડેફનેસ આવ્યું તો ઘણા વિચાર કરવા સેન્સરી ન્યુરોનલ ડેફનેસ
the long QT1, QT2 and QT3. So we already discussed the genes behind associated. These are the potassium channel associated, loss of function of potassium channel. These are the loss of function of the potassium channel KCNH2, and these are the gain of function of SCN5. Previously we discussed in Lugada the loss of function in SCN5. So mainly the associated trigger in swimming or exertion, which lead to cardiac arrhythmia. Exertional activity lead to lethal in long QT1. And any auditory trigger or postpartum, maybe middle-aged person or female. And during the rest and sleep, the long QT2 will provoke the arrhythmia. So these are the ECG findings I want to discuss. These are the.
So, Laljee, actually, a slide, sir. So, how childhood ma ratio equal or in adulthood ma ratio change થઈ જાય? Any explanation?
Explanation behind, sir. Such.
So, number one is says to be related to the reporting. Reporting થાય ત્યારે એક હોય અને નંબર 2 ઘણી બધી વાર તમારું જીન ક્યારે મેનિફેસ્ટ કરે એના ઉપર આધાર.
See, you see the many neurological constitutional disease manifested at the age of 50. Example I give is the spinocerebellar ataxia. You see, they come at the age of 45-50. But if you see the family history, already present in 3 generations. So when you do the genomes in such people, they are already present. They are not manifested. Why they are not manifested? The reason I am giving is that genes are always getting repaired. And 2 processes going on. One, that gene promoter and that gene suppressor. You see, and when this balance is there, then disease don't manifest, even though you find the genes, right? But as age advances, promoter takes upper hand over the suppressor, and hence the disease is manifested at the late age, Huntington's. You find the triplet at childhood, but they don't manifest at the age of, till they are 45-50 years. The reason, because I had recently a patient, and so I inquired that why they should develop at this age as such. If I have done the genomes of this thing, then it will be positive, and it will create a nightmare to that patient. You see, should I go for it? Yes. Today the treatment is not there. Tomorrow when you find the imbalance of this promoter and suppressor, then CRISPR will come into picture.
In general, autosomal dominant disease will manifest in childhood or in adulthood.
Adulthood.
Right? And autosomal recessive will manifest in childhood or adulthood.
Autosomal recessive.
Recessive.
Autosomal recessive mainly which time?
Childhood, right? So તમે જ કીધું કે આ બધું autosomal dominant છે.
Dominant.
So there are all the chances કે આ બધું જ્યારે manifest થાય ત્યારે આ ratio alter થઈ ગયું.
See, that's the thing is,
Pregnancy, lactating female, middle age, and these are when person began.
So these are all lateral thinking which goes simultaneously. જ્યારે આ બધી rare બીમારી તમે બોલો ને ત્યારે comprehensive વિચારવું બહુ જરૂર છે. બાકી તમે fill in the blanks કોઈ દી થાય નહીં.
you only learn from rare disease. From common disease, you don't learn that much.
Yes. Very good.
Our brain can see only.
Yeah.
So we can't.
તમે
We cannot guess the.
એક વસ્તુ સમજજો લાલજી કે આજે માયોકાર્ડિયલ ઇન્ફાર્ક્શનની જો તું જે ટ્રીટમેન્ટ કરે છે ને એ આજથી 100 વર્ષ પહેલા લોંગ QTC ફેઝમાં હતી. સમજણ? હવે એ લોકો ક્યાંથી પહોંચતા અત્યારે FFR આઈવસ લગી આવી ગયા છે. આ વસ્તુ બી એક સમય લોંગ QTC ની આવી ગાઈડલાઈન હશે કે આજે ડાયગ્નોસિસ કાલે ટ્રીટમેન્ટ થઈ ગઈ. તો આ ફિલ ઇન ધ બ્લેન્ક્સ જે છે ને એ તમારા જેવા યંગસ્ટર કોઈનું બ્રેઇનસ્ટોર્મિંગ થઈ જાય તો આગળ જઈને કંઈક કરે.
પણ તમને ખબર હોય કે આ abnormality છે, અને આ અવેલેબિલિટી શક્ય છે, then and then you can act it as such.
Someone bring the ECG Brugada to Brugada himself, and this is the Brugada, no, this is the acute MIC. Really,
બ્રુગાડે સ્પેનમાં ગયું એટલે આપણે માની લીધું.
these are true.
એ ત્રણેય ભાઈઓએ આખું જીવન આ જ કર્યું છે. બરાબર? એટલે આ બ્રુગાડાના આટલા બધા ડિટેલ તમને બોલી શકીએ. પણ હજી એ કદાચ 10% જ છે.
Absolutely.
Complication as well, regular fibrillation, torsion, pollution, polymorphity. These are the triggering events as already we discussed. And first cardiac event already mentioned in this slide, the emotional swimming and associated with long QT one. Only one thing I want to mention that beta blocker is very effective in long QT one. We will discuss in later on. So these are the ECG long QT one broad-based T wave. You can see the broad-based T wave with long QT. These are the low amplitude notch, like the biphasic T wave. And these are biphasic T wave. And long QT3 is isoelectric segment followed by narrow-based T wave. Later on, very like base is isoelectric. And these are the mimics, like routinely we miss this long QT1 or long QT3. In long QT2 it is clearly you can differentiate. So associated condition is Anderson-Tawil syndrome and Timothy syndrome. Long QT7 is Anderson-Tawil as well as long QT8 is
કેટલું બાકી છે ભાઈ?
syndrome. Sir, a differential diagnosis and then management.
9:30 થયા છે એટલે 5 મિનિટમાં પતે એમ છે કે સેકન્ડ કરવું પતી જશે?
So mainly this Anderson-Tawil syndrome associated with the triad of periodic paralysis, patient having dysmorphic facial feature problem, acromegalia and ventricular arrhythmia, prolonged QT, bidirectional VT apart from then digoxin toxicity and chronic poison, and these are the differential diagnosis for bidirectional VT. So Timothy syndrome, it is a CATNA1C mutation with long QT8 and associated with syndactyly hypoglycemia, recurrent hypoglycemia with suspected patient having the young age, and these are the underlying causes. So apart from there, differential diagnosis, long QT, MI, cerebral giant T wave, syncope, seizure, Brugada, HOC and coronary artery spasm, resulting spent, arrhythmogenic, hyperventricular dysplasia, pulmonary hypertension. So for diagnosis, mainly ECG is first and foremost tool for initial assessment. Ambulatory ECG monitor, we can do exercise stress testing to induce the QT prolongation during recovery or during peak time. So gene testing, if SWAT score is positive, these are the, they mention electrophysiological studies not recommended. These are the opposite in Brugada syndrome. For diagnosis, electrophysiological study is necessary, but here is not always. Provocative testing is epinephrine, QT stress test, mental stress, supine to standing ECG, routinely we clinically not using them. These are the SWAT score criteria. Score less than 1, rule out. More than 3 is these are the score actually, the calculator available. So family counseling.
કેટલો સ્કોર હોય તો સિગ્નિફિકન્ટ થાય છે?
Sir, here more than 4 or 4 or more than 4. Between the intermediaries. Family counseling for all ECG up to the older family members. Pregnancy, no as such contraindication for pregnancy. Malignant VT decrease with pregnancy, but increase during the first 9 months of postpartum, especially associated with long QT. And beta blocker, especially the nodular propranolol, useful in this condition. These are the swimmer associated with long QT, for example. Treatment point of view, first thing is lifestyle modification, avoid all the possible stress factor, care during pregnancy, educate all the family member, and each one should undergo the
Most of the lifestyle modification में वो कि exercise करो, नहीं है तो हमारा lifestyle modification ना exercise ना.
see diet because
સાહેબ પૂછે સ્વિમરથી એને લોંગ ડ્યુટી હતું?
yes sir.
ભાઈ છે જીવે છે કયા કન્ટ્રીના કયા હતા? નામ બાપ દાના બોલમાં
ગૂગલ છે.
તો તમે જે સ્કોર બતાવ્યો
Yes.
એ ઈસવીસન પૂર્વે કેટલા વર્ષ પહેલાનો સ્કોર છે?
Sir, it was previously used.
એટલે ક્યારે 10 વર્ષ પહેલા 20 વર્ષ પહેલા હમણાંનું કંઈ નવું આવ્યું?
It was initial 20th century. અત્યારે recent
આ 2022 માં ESC માં કંઈ ગાઈડલાઈન આવી હતી?
20
માં 2 વર્ષ પહેલા જ હતું આવું કંઈ?
last update was 2017.
2017? હા, ઓકે.
This slide is from the 2017. And then again consensus meeting was there. They defined what is such no changes the
કોઈ
criteria.
અપડેટ નથી right?
So avoid the medication which prolong the QT interval. Beta blocker mainly used for the long QT one. Use of beta blocker with sodium channel blocker, maxillating, improve the protection. Sodium channel blocker when we use the regulazine, maxillating, flecainide.
Flecainide was a tinted drug. Who uses it? Nobody uses it.
In the pocket use.
It is a tinted drug.
Mainly sir, maxillating use.
That's the thing. Or ranolazine. Flecainide one.
So Nandazole is preferred in this category.
મળતી નથી ક્યાં મળે છે?
Again,
આ તો હિપેટોલોજીસ્ટની ડ્રગ હતી, પોર્ટલ હાઇપરટેન્શન. બીટા બ્લોકર યુઝ ટુ રિડ્યુસ ધ પોર્ટલ હાઇપરટેન્શન. બેસ્ટ ફોર ધ નેનો. પછી ઇન્દિરાની મળે છે નેડોલ.
yeah.
તો પછી જાણી દો.
So beta blocker is mainly used in long QT1 and maxillating is used in long QT3 for treatment as well as. So electric defibrillator and brief medical therapy we can give for first line treatment. Temporary transvenous pacemaker we can use for repressing isoproterenol to increase the rate, as well as if we consider the ICD for recurrent syncope or cardiac arrest, in spite of having beta blocker maximum dose, then we use on this high risk category and refractory risk cardiac transplantation. These are the long QT syndrome. Every patient must undergo genetic counseling as well as genetic testing, and ICD is recommended if having history of sudden cardiac arrest or rescue from the cardiac CPR within the 1 year period. So this showing the long QT syndrome with resting QTC greater than 470, beta blocker class 1 indication. If patient having long QT syndrome which is greater than 500, then patient who does not have any symptom give beta blocker maximum tolerable dose. If patient doesn't tolerate the beta blocker, thinking about ICD class 1 indication. And these are the flow chart summarized. If long
If a asthma patient who is intolerant to beta blocker and is diagnosed with a long QT without any symptoms, without any event, should we go for ICD?
No, sir.
We
asymptomatic patient
only if there is an event, significant event.
He is a potential person once again.
Yes.
The reason I am putting, now people take a lot of things with a pinch of salt. 40 years male, CEO in a multinational company, right? And if he gets something, whole company crumbles. In that situation, I will go for it. Again, it is the individualized and precision approach rather than a blanket approaches.
રિસ્ક બેનિફિટ તમે ડિસ્કસ કરીને તો આમાં સિલેક્ટિવ બીટા બ્લોકર હેલ્પ નહીં કરે.
No,
કરશે.
sir. Yes, sir.
પછી તમારું પ્રેગ્નન્સીમાં એક સ્ટેટમેન્ટ હતું વેન્ટ્રિક્યુલર અરિથમિયા હવે શું હતું?
So metoprolol is less effective in this group, and pregnancy is safety consideration. So,
એક સ્ટેટમેન્ટ હતું જેમાં પ્રિવેન્ટ એટલે પ્રેગ્નન્સી વેન્ટ્રિક્યુલર અરિથમિયા પ્રિવેન્ટ કરે છે કે પ્રિવેન્શન માટે તમારે આપવાનું એવું શું હતું?
પ્રેગ્નન્સીમાં ઓછા થાય,
How?
less occurrence.
How?
Postpartum 9 months occurrence વધે છે.
ના બટ હાઉ ધીસ ઇઝ આ મેલિગ્નન્ટ વેન્ટ્રિક્યુલર અરિથમિયા ડિક્રીઝ પ્રેગ્નન્સી કઈ રીતે? આમાં ક્યાં લખ્યું છે? મતલબ ઇટ્સ ઓલ સોર્ટ ઓફ ક્રોસ ઇન પ્રેગ્નન્સી, and if there is UTC અને malignant ventricular કયું કે
એના સ્પેશિયાલિસ્ટ પર જવું પડશે. ઇલેક્ટ્રોફિઝિયોલોજિસ્ટ ઓફ